We are live now, sir.
Yes, madam, we are live now and we are starting. So, good evening, doctors and all the participants. On behalf of Shield Healthcare, I welcome all the dignitaries, including the chief guest, guest of honor, convener in today's session on fetal invasive procedures, diagnostic and therapeutic, organized by Fetal Medicine Committee (AMOGS) and Aurangabad Obstetrics and Gynecology Society in association with Shield Connect, a knowledge sharing platform of Shield Healthcare. So now it's time to start the session with the introduction of emotions. That is Dr. Sunita Khetkar, madam. Madam is the consultant and director of Khetkar Maternity Hospital for last 14 years. She did her MBBS and DGO, and she has work experience as an ex-registered at Wadia Maternity Hospital, Mumbai, ex-consultant at MIT Multi-Speciality Hospital, Aurangabad. And in terms of field of interest, madam has keen interest in the obstetrics, sonography, infertility, and menopausal health. So with this short introduction, I request Madam to take over the session for further proceedings. Thank you very much, and over to you, ma'am.
Thank you for the kind words. At the onset, I'd like to invite and introduce Dr. Sujit Konkar, sir. Sujit Konkar, sir, has done MBBS and MD OBGY from GMC Aurangabad. He has done basic USG training course at Dr. Bimal Sahni Sir's Sonocare Center. He is FMF certified for 11 to 13 week scan, preeclampsia screening, Doppler ultrasound, and fetal abnormalities. Presently, he is Secretary of Society of Fetal Medicine, Marathwada chapter. His Sri Hospital is Foxy approved USG training center, where most of us have already got training there. He has keen interest in fetal ultrasound. He is chairperson of Fetal Medicine Committee, AMOGS. I welcome you, sir. I request sir to share his thoughts. Sujit, sir.
Yeah, good evening, friends. Thank you, Dr. Sunita, for nice introduction. I'm delighted to give this welcome speech. Our chief guest today, Dr. Sadhana, ma'am, respected Sadhana, ma'am, for today's webinar. Ma'am, we are eagerly waiting for your words of wisdom and advice for this webinar. I welcome our guest of honor, Dr. Maheshwari, ma'am. Welcome our President, OBGY Society, ma'am, and Secretary Vaishali Surase, ma'am, for this webinar. All our three pillars of today's webinar, last but not least, welcome all delegates who have logged in. Today's webinar is somewhat different. Everything is related with fetal invasive basics and advanced. So, and give attention to this webinar. Thank you. Over to you.
Thank you, sir. Now I'd like to invite and introduce Sadhana Gupta, ma'am. Madam, who is chief guest for today. Madam is co-chair of SAFOG NCD committee. She is president of North India Gynecologist Forum. She was vice president of Foxy 2016. She is ICOG Governing Council member 2015 to 21, and for that she has received Best ICOG Governing Council Member Award in 2021. Madam is past chairperson of Foxy Safe Motherhood Committee, and she has received Best Committee Award for that. Madam is a country representative to SAFOG and WHO on key women health issues. She is key organizer of national and international conferences, Saving Mothers 2016 and 19. Then Abhigyan Foxy Figo SAFOG 2021, Prevention of Stillbirth 2021. She was honored at national and international forum for her exemplary work to reduce the maternal mortality, community services, and women empowerment. She is director and senior consultant at Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. And she is now presidential candidate for election of Foxy presidential candidate for the election of 2023. Best wishes, ma'am. I'll like to invite madam and ask her to share blessings for us. Sadhana Gupta, ma'am.
Thank you, Anjali. And first of all, hearty thanks to AMOGS and the Aurangabad Society for given this opportunity to be with all of you. My sincere regards to Dr. Sujit Konkar, Dr. Anjali Vare, Dr. Vaishali, Dr. Sunita Khedkar, and for bringing this program up to this very, very important issue. So this is what we were just discussing, that the fetal medicine is an area which actually has a great future, because now with the genetic screening, which has become a normal protocol, with the very, very high quality ultrasound machine, the next step where our professional body has to work together with the radiologist and with the genetic people, that is the interventional issues into the fetal medicine. So this is a futuristic program, and we have to create the second generation who can do the interventional procedure. We have to follow many, many rules in our country, because PCPNDT, a very, very strict rule is there in our country. So my heartiest congratulations to Dr. Saurabh, Dr. Prashant, and Dr. Chinmay, who is going to speak on the amniocentesis CVS multifetal pregnancy, which is again an issue with a very, very commonly taken ovulation induction drug, ART technology, that we are dealing with a lot of multifetal pregnancy and then fetal anemia because of various reasons. It may be Rh negative, it may be viral infection. So the two things are there. First of all, we have to understand this knowledge to all OB-GYN who are doing the obstetrical practice, that how to interpret the result of ultrasound. And the second knowledge, that what we can offer. So when we see the fetal height drops, suddenly we say, no, this fetus has got no good prognosis. But with the interventional procedure, with the intrauterine blood transfusion, we can save the baby. So first step is the knowledge transmission, that what is available, who are the centers around us in our state, in our region, where are the hospitals, who are the people who can take up this procedure. And thirdly, the skill and expertise in these modalities, which are earned with a great experience, with a great period of observation. So it is not an easy thing to learn, because it is an invasive procedure, a mother and fetus and the family, and sometimes the economic issues are also there. So hearty congratulations to Fetal Medicine Committee of AMOX and the Aurangabad Society. And Dr. I convey my regards to Dr. Rajan Singh Pardesi and Ajay Mane. I have been to Aurangabad so many times. It is a lovely city, and always they do wonderful programs in the fetal medicine. So I've always enjoyed it. So hearty congratulations. And thanks for bring this invite. And I also convey my regards to Dr. Bharti Maheshwari, who is joined, I think, as a guest of honor. So once again, hearty congratulations. I will be boarding train, and as soon as I board the train, I will again log in to listen and learn from the stalwarts, Saurabh, Prashant, and Chinmay. Thank you once again. Thank you.
Thank you, ma'am, for taking time from your busy schedule, and we wish you all the best for your presidential candidature. Our guest of honor is Dr. Bharti Maheshwari. Madam is HOD of Department of OB. Madam is yet to join, I think.
Yeah.
She is HOD of Department of Obstetrics and Gynec at Muzaffarnagar Medical College. We welcome Madam. And now I'd like to invite and introduce Dr. Anjali Vare, Madam. Madam is President of Aurangabad OBGY Society. She has done MBBS and MD from Government Medical College, Aurangabad. She is consultant at Vare Hospital, Aurangabad. She is practicing since last 27-28 years with high-risk pregnancy, and she has huge experience in high-risk pregnancy and ultrasonography. She has conducted many adolescent health camps in schools and colleges, and she has worked in obstetrics HDU. Welcome, ma'am. Now I'd like to invite our secretary of our society, Dr. Vaishali Surase. She has done DNB at JJ Hospital and Grant Medical College, Mumbai. She has taken ICOG fellowship in IVF and Fox USG fellowship. Regarding her work experience, she has worked at Vadia Hospital and Seven Hills Hospital as senior registrar. Then she has worked as infertility consultant at Medical College of Devran, Ratnagiri. And now since last 14 years, she is practicing in Aurangabad at Mediart Hospital as gynecologist and infertility specialist. Currently, she is secretary of our society. Welcome, Dr. Vaishali. Now, I'll like to invite Dr. Anjali Vare Madam to invite and introduce our first speaker, that is Saurabh Chaudhary, to give his talk.
Good evening, friends. First of all, I will like to congratulate Dr. Sujit Konkar and Fetal Medicine Committee AMOX for arranging this wonderful webinar. We are having too many webinars arranged by Dr. Sujit, which are very much useful. And we are lucky to have with us speakers like Dr. Prashant and Dr. Saurabh and Dr. Chinmay. I will like to introduce Dr. Saurabh Chaudhary. He is a consultant radiologist. He has done his MD radio diagnosis and fellowship in advanced obstetric and gynecological ultrasound from Kochi. And he is a member of Society of Fetal Medicine. I welcome you, Dr. Saurabh, and please start your talk.
Thank you, ma'am, for your kind introduction. First of all, good evening, all of you. Can you see my screen now?
Yes, sir. Visible, audible.
Yes, okay. So, good evening, everyone. First of all, I would like to thank Dr. Sujit Konkar sir and Dr. Prashant Asegawkar sir for giving me this wonderful opportunity. And today, I will be talking on fetal invasive procedures, two main procedures that are amniocentesis and chorionebular sampling, that are the part of our daily practice and perform most commonly in day-to-day practice. So I am going to cover my talk in following headings. First of all, why do we need these invasive tests? Then pre-test counseling. Then about the procedure itself, that is chorionebular sampling and amniocentesis, indications of the procedure, and post-procedure care, complications, and also I will be showing some of the examples that I have done. So first of all, why do we need these invasive tests? So we need to know that there is difference between genetic screening and genetic testing. Screening is the part of the general is applied to all the population, where we get to know whether a particular woman is at the increased risk of having a fetus affected by a genetic disorder, whereas the genetic test is done for diagnosing a specific condition or genetic disorder. Whenever we are having some soft markers on the ultrasound, or if we are having any particular structural abnormality on the ultrasound, then we have to perform a particular genetic test for confirming confirming our diagnosis, because we cannot put all the pregnant women for the invasive test. That's why the screening is also as important as a genetic test. So why invasive tests? Because there are large number of birth defects that are associated with the genetic abnormalities, and day by day we are seeing the increasing in the number of genetic abnormalities because of the advanced maternal age. Almost 30 to 50% of the first trimester miscarriages are due to the chromosomal abnormality. Almost around 25% of the admissions in the pediatric hospitals are due to some conditions which are associated with the underlying genetic abnormalities. Genetic abnormalities can affect all the major systems of the body. It can affect any race, any age, and also any gender. So what are the usual main indications that we get for the invasive tests? The common indications are the late maternal age or advanced paternal age, then previous child having any chromosomal abnormality or single gene disorders, high risk in the screening test. And the most common indications that we get in our day-to-day practice are the high risk in the screening test, soft markers on the ultrasound, and structural abnormalities on the ultrasound. Then coming to the fetal intervention, our goal is to diagnose the prenatal abnormality. Can you hear me?
बता देती कि वो नहीं हो रहा है लॉगिन बताया था लेकिन जब तक हम
Our goal is to diagnose the prenatal abnormality to avoid complications, and later on, after the child is born, then the problems that child and the parents will face and the family will face, that we have to avoid those complications and the problems they will face. That's why our goal is to diagnose the prenatal abnormality. While doing so, we have to consider the risks and the benefits both, And also we have to understand that it is a maternal fetal intervention, not only the fetal intervention, because we are passing the needle through the maternal abdomen, and maternal safety is almost the important for us. There are various research articles and papers that have been published, and you all can go through these papers for detailed information guideline. So coming to the fetal intervention, most important part of the process is pre-test counseling, because I feel that pre-test counseling is more difficult than the procedure itself, because you have to involve the mother, her relatives, treating obstetrician. Also, we had to take a genetist many a times for some rare abnormalities. We have to counsel the geneticist. We have to ask which test would be better for this particular condition. We have to ask for the family history, and also whenever we are getting some abnormality on this ultrasound, we have to give general information about the suspected genetic abnormality. For example, if we are getting unossified nasal bone, we have to tell parents about that we are suspecting a Down syndrome baby that will have mental retardation. And also, if we are getting some other structural abnormalities like cardiac defects, we have to tell the mother that if your baby is going to have a major heart anomaly, and even if this uh, genetic test comes out to be normal, there is a strong probability that baby might require a major cardiac surgery after the birth, and for which they have to be prepared for the NICU admissions, and also we have to explain them the expenses that are involved. In the some cases where the abnormality is very lethal, we have to give the option of termination to the parents. And also, whenever the abnormalities are non-lethal, like mild hydronephrosis or unossified nasal bone, or like ecogenic boil loops, then we have to keep the baby for the fetal surveillance. We have to give a good intrapartum care, and then we have to follow up the baby after the birth. Always, it is important to take an informed consent of the patient. Coming to the first procedure, chorionic villi sampling. Chorionic villi sampling is the easiest, earliest technique that is used till date for the genetic abnormality testing. It can be done by transvaginal, transcervical route. The most preferred route and safest route is transabdominal. First of all, whenever we are getting a patient for chorionic villi sampling, we have to first of all confirm the abnormality that we are going to test. For example, if we get a referral for unossified nasal bone, first of all, we really have to confirm whether the particular abnormality is there in the baby. Then we have to perform a dating, also look at the dating, because if you are doing it before 11 weeks, there are high chances we might get an inadequate sample, or we will not get a particular result. We have to look for the placental location. If the placenta is posterior, then we have to tell the parents accordingly that this procedure would be difficult, and we might wait for another 4 weeks or 5 weeks to do the amniocentesis. We have to look for the RH status of the mother, and then we have to us under all aseptic precautions, local anesthesia, we usually use 18 gauge spinal needle, and we have to be careful that needle and syringe should be heparinized to avoid clotting. While whenever we are giving suction to the placenta, then there are high chances that some hemorrhagic aspirate may come along with that. And if our needle and syringes are heparinized before the procedure, then it would be better to collect the sample. And then after collecting the sample, we have to send it in the proper transport media that is like shown in the this image. Then coming to the procedure, whenever we are taking the patient for the chorionic villi sampling, we have to first of all locate the placenta. We have to clean and drape the maternal abdomen, and after locating the placenta and using the local anesthesia, it is good to use a 18 gauge needle. And in this particular video, you can see the needle is entering the abdomen and then into the placenta, and then it moves up and down till the villi are loosened. And after that, you have to take out the stillet, and you have to apply some suction. After applying the suction, again you have to move the needle up and down, and so that whatever villi are loosened, that will come up in the syringe. And again with the positive suction, you have to take out the needle from the abdomen. What are the difficulties that we may face during this procedure? Most common difficulty is the posterior and low-lying placenta, and poor yield of the corionicula sample, because if the procedure is done before 11 weeks or even after the 14 weeks, the yield of the corionicula sampling may not be very good. And even if you are doing it when between 11 to 14 weeks, sometimes we may get inadequate sample and culture failure, and then we have to consult the patient again for the amniocentesis. If sometimes there is chances of getting mosaicism, there are 1% of the CVS samples, there is presence of more than one cell line during the cytogenetic analysis. In such cases also, we have to consult the parents about the particular condition, and we have to then do the amniocentesis. Post procedure care, we have to monitor fetal heart rate. Even we can you can call back the patient after 1 week and look for the fetal heart rates, check for any placental or retroplacental bleed, and you should always advise bed rest and home stay for at least 1 to 2 days. Avoid all the exertion, and you can give oral antibiotics for 5 days. And if the mother is Rh negative, then full dose of anti-D should be given. And in my particular practice, I give weekly IV progesterone injections and call back the patient after 1 week and 2 weeks again to check the fetal heart rate and just for the fetal well-being. Complications that we may get during the CVS is most common is paravaginal bleeding or spotting. We usually, which is very less and self-limiting, we don't have to do anything for that. Sometimes we might get infection in like 0.3% of the cases, rupture of the membranes, RS sensitization, and pregnancy loss in up to 0.2% of the procedures. Then coming to the next procedure, that is amniocentesis. This is the most common intervention that we are doing in our practice, and it is a OPD or daycare procedure. It is the easiest technique for doing. As I told you, the counseling part is very difficult, but as such, the procedure is very simple. The preferred route is transabdominal. We have to confirm the fetal abnormality, as again that we do in CVS. We have to do a dating before doing the procedure. The amniocentesis usually should be done after the 16 weeks. We have to confirm the placental location. If the placenta is anterior, then we have to wait for a few more weeks, or if we are choosing the transplacental route, then we have to be very careful to look for the hematoma. Then again, we have to confirm the RS status. We have to take all the aseptic precautions. Give the local anesthesia is not always necessary. If the patient is very anxious, then you might choose to give some local anesthetic before the procedure. And in amniocentesis, we don't use 18 gauge. We use a thinner needle, 20 or 22 gauge needle for the procedure. Technique is we have to take a thinner needle and keep the needle at approximately 1 centimeter distance from the probe. Needle should be angulated so that full length of the needle and tip should be seen while doing the procedure. As you can see in this video, needle is kept away from the placenta and also the fetal parts. After the entry into the amniotic cavity, approximately 20 cc of the fluid is taken into the syringe, and we have to make sure that we discard first 2 to 3 cc of the fluid to avoid the maternal cell contamination. Difficulties that we face during amniocentesis are we may get a dry tap, hemorrhagic tap. Sometimes if we get a dry tap, we have to do multiple punctures that again increases the risk of infection as well as the leakage of amniotic fluid. If the placenta is anteriorly placed, then again, if we have to go through the placenta, then we may get placental hematoma. If there is severe oligo, again finding a good pocket to put our needle is difficult. And if sometimes if we have to do for any particular cause, we have to do early amniocentesis, it would be difficult because there are complications like amniotic separations, high chances of culture failure, and amniotic fluid leakage. I personally feel that amniocentesis is better than doing a CVS because the advantages are it is a low risk procedure. The fetal loss is almost half as compared to coronavirus sampling. The percent of the fetal loss is approximately only 0.1% as compared to 0.2% in CVS. With high diagnostic accuracy, it is a simple procedure and can be performed up to from the 16 weeks. Complications again, as I mentioned, you can the patient can have small amount of spotting or leaking. There can be chorioamnitis, injury to the fetus if our needle is not put in the proper, or there are increased movements of the fetus. Then there might be some injury to the fetus, which is usually not very significant. And if the mother is RS negative, then you can get RS sensitization. And in 0.2% of the fetuses, we will get fetal loss. After doing the procedure, choosing the right test is also very important, as much as doing counseling and doing the procedure in a correct way. And usually these are the tests that we are usually advising. Most commonly, we advise a conventional karyotype, which takes around 7 to 14 days time for the results to come. And after that, fish, we usually advise with karyotype because the turnaround time is very quick. We usually get the report in 2 to 3 days, and we get rapid assessment of the major aneuploidies, that is 13, 18, and 21. And nowadays we are advising chromosomal microarray because we can detect more number of abnormalities and clinically significant chromosomal abnormalities. And also whenever in genetic disorder in which the familial mutation has been identified, we have to do a pre-implantation genetic diagnosis, which will take around time of around 1 to 2 days. And whenever we are doing a test focusing on a specific disorder, then we have to do a molecular DNA testing like Sanger. So coming to the examples, this is the first case one. This was the case that came to me in the early pregnancy itself, around 8 to 9 weeks. And that time, there was some CRL discordancy in the both of the fetuses. Then the patient came to me at the 12 weeks, and it was a DCDA pregnancy, and fetus, as you can see in this image, fetus A had shown increased NT and also unossified nasal bone, while fetus B was completely normal, and the nuchal translucency was normal, and also the nasal bone was very well seen. We counseled the patient for the abnormality in the particular fetus, and we also told them about the high risk of the associated genetic abnormalities, specifically Down syndrome. And then we did chorionic villi sampling at 13 weeks itself, and the result came out positive for the Down syndrome for fetus A, whereas the fetus B chorionic villi sampling report was absolutely normal. Then after the reports came, we again called back the patient at 16 weeks, and we did a selective reduction of the abnormal fetus, and rest of the pregnancy was continued till term, and the patient delivered a healthy, normal other baby. Then case 2, again, this is the unossified nasal bone, and there were 2 soft markers, intracardiac echogenic focus. We had counseled the patient for the increased risk of the associated chromosomal abnormality, and we did amniocentesis at around 22 weeks, and the results came out to be positive for trisomy 21, and patient decided to terminate the pregnancy after that. This is the third case, in which we can see a right aortic arch with the left ductus and apparent left subclavian artery. Apart from this, there was no other structure abnormality in the fetus, and the patient was told about all the associations of the chromosome abnormalities like DiGeorge syndrome, 22q11 microdeletion. And after that, after confirming that there are no other major structure abnormalities, we did amniocentesis, and results came out to be normal for this particular case, and the patient then continued the pregnancy, and till that she is on the follow-up. Right now she is around 34 weeks, and the baby's the fetus growth and amniotic fluid Doppler parameters are all normal. Then case 4, this patient particularly came at around 19 weeks, and the only positive finding in the uh, ultrasound was aberrant presence of an aberrant right subclavian artery. Other than that, there were no any other major soft markers or any structural abnormalities. We counseled the patient and we did a amniocentesis for chromosomal macroarray, and reports came out to be normal, and that after that she continued the pregnancy. This particular case is very interesting because the patient has very bad obstetric history. First 3 G1, G2, G3 were spontaneous abortions at around 12 weeks of gestation. Then at her fourth pregnancy, she had a female child of 4 years of age, and again there were back-to-back 3 miscarriages, spontaneous abortions at around 8 to 12 weeks. Now she was G8, and her first trimester anti-scan and even combined screening was done in Pune, where the reports of the combined screening were intermediate risk. That's why NIPT was done, which showed the low risk for the chromosomal aneuploidy. He came to me at 22 weeks for the anomaly scan, and I found out the presence of aberrant right subclavian artery. Then after that, we involved the treating obstetrician, and also the we took opinion of the geneticist, and she also took one opinion at the tertiary care center, where she was advised against the amniocentesis because there is even 0.1% chance of the invasive 0.1% chance of the miscarriage. We should not take in such cases because this pregnancy was very precious, and NIPS had already reported a low risk, and that's why we did not do any invasive tests. And that's why it is very important to note that even the cases where we should hold back and avoid the invasive testing, for even that 0.1% of chance of the miscarriages. I'm very happy to share that only 2 days back she delivered a very healthy baby. Then case 6 is a single gene disorder. There was history of consanguineous marriage, and previous 3 spontaneous abortions were there at around 3 to 4 months of gestation, and that were mainly due to polyhydramnios. And the last pregnancy product of conception were sent for the evaluation of the chromosomal abnormality, and in which there was particular variation in the BSND gene, which is associated with the Bartter syndrome, which has the characteristics of sensory neural deafness, and also we get the which is an autosomal recessive type of abnormality. And after the birth, there are 2 types of forms, which is the neonatal form. They usually present with the premature birth and associated with polyhydramnios and low birth weight, and usually develop very threatening dehydration in the neonatal period. Whereas the classic Bartter syndrome, they present later in life and not in the antenatal period, and they are usually asymptomatic. So in this particular case, when she came to me again at around 17 to 18 weeks, there was presence of polyhydramnios, and we did a Sanger sequencing, and the results came out to be homozygous for the BSND gene, and that's why after consulting the geneticist, the pregnancy was terminated. Thalassemia is very common in our region, and again, whenever the parents are carrier, or if previous baby is affected, we get preferences for testing the baby for the thalassemia major. In this particular case came to me, and we did amniocentesis on the insistence of the parents. We did amniocentesis around at 15 weeks 6 days, and the results were positive, and pregnancy was terminated after that. This particular case is the patient came to me at around 27 weeks. She missed the anomaly scan, and on 27 weeks, the profile view of the fetus showed the mid-phase hypoplasia with the typical Bander phenotype, and also there was epiphyseal stippling at the lower end of femur, and that's why we suspected a Bander phenotype with chondrodysplasia punctata. Later on, she went to for the second opinion in Agra and got her amniocentesis test done there for the whole genome exome, and the reports were normal. We also the patient also consulted orthopedician, and we involved geneticist for the consultation, and she was reassured that the prognosis of the baby would be good because there were no associated chromosomal abnormality. Again, one more case of single gene disorder in which the previous baby was having progressive encephalopathy and developed brain edema, and the positive there was a single gene disorder of NAXD gene was variation in the NAXD gene was found, and in present pregnancy again we did a amniocentesis at around 16 weeks, and patient was the baby was found to be homozygous for the single gene disorder. This particular case is the patient was 40. The mother was 45 years old, and she was having twins IVF pregnancy, and in her anomaly scan there were presence of multiple soft markers in both the fetuses. One of the fetus had shown single umbilical artery with echogenic focus. Other one had mild ventriculomegaly and echogenic focus in the heart. So we did the amniocentesis of both the fetuses at around 22 weeks, and the results came out to be normal, and she is under the follow-up now currently at around 34 weeks. This is again the case in which there was one fetus, the previous D1 was the abortion at 12 weeks, and G2 was a healthy child. And in this present pregnancy, she was having a DCDA twin pregnancy, and around 21 weeks 3 days, the fetus showed mild hermaphroditism and single umbilical artery, and we did amniocentesis, and the results were normal. This particular case is the parents were carrier of the thalassemia, and NT scan was done at Aurangabad by Dr. Prashant Asegawkar, and he found out the unossified nasal bone. So parents were counseled about the chromosomal abnormality, as well as they knew the risk of thalassemia. And we did amniocentesis at 17 weeks, and both the amniocentesis as well as the chromosomal microarray reports were normal. Again, this is one case which came to me at around 19 weeks, and we found out there is presence of aberrant right subclavian artery as well as unossified nasal bone, and amniocentesis was done, and which we found out again one Down syndrome positive, karyotype of the Down syndrome positive, and pregnancy was terminated. So my take-home message for this presentation would be, even if the fetal invasive procedures are done by radiologists or by fetal medicine consultants, the whole process is a team effort. As I have told you, many a times we have to take opinion of the treating obstetrician, we have to call pediatricians, we have to call pediatric cardiologists. In cases like chondrodysplasia punctata, we have to take opinion of pediatric orthopedicians. And most important part of this process is counseling and choosing the right test for the patient. We also have to consider the affordability of the patient in our region, because many of the patients are from poor financial background. Most challenging part is convincing the patient for the procedure, because the many times the affordability is poor. Hence, we need to talk to the patient, also the genetic labs, their charges, and then decide the most appropriate thing for the patient. Thank you for your patient listening.
Thank you, Saurabh. Thank you, Saurabh sir. That was excellent lecture, especially the case examples which you told gave us clear-cut idea about take-home messages. Thank you once again. Now I'd like to welcome Dr. Bharti Maheshwari ma'am. She has joined. Can we have her CV? Bharti Maheshwari ma'am is professor and head of Department of Obstetrician and Gynec and IVF at Muzaffarnagar Medical College. She has done diploma in IVF and reproductive medicine in Germany. She is chairperson of FOXY MTP committee 2018 to 20. She is governing council member of ICOG. She is secretary of UPCOG, president of Meerut Obstetric and Gynec Society. She is author and editor of many textbooks of obstetrics and gynec. She is national coordinator of MTB committee 2015 to 18.
Hello.
Yes, welcome, ma'am.
Yeah. Can you hear me?
Yes, ma'am. You are
Yeah.
visible audible.
So,
I will
first of all, greetings from Uttar Pradesh, UP, and it's here. Congratulations to EMOX as well as Aurangabad Society for organizing such a informative webinar, especially focusing on fetal medicine. And I am really grateful that you have given me opportunity to interact all of you. I have some issue in the login. That's why I couldn't log in. And Dr. Sujit, he's the chairperson of Fetal Medicine EMOX. So thank you, Dr. Sujit. And regarding Aurangabad Obs and Gynae Society, President Dr. Anjali, Secretary Dr. Vaishali, as well as Coordinator Dr. Sunita, and all speakers. It is really a very important issue because nowadays we all of us know that there are lots of issues where and lots of modalities where we can identify congenital anomalies earliest. So this is the time when we have to focus and emphasize on the preconceptional counseling, identifying the cases of the bad obstetrical histories or who can have such a treatable causes or identifying so that further management can be done. And ultrasound definitely has a very good role. Fetal medicine has got lots of advantages and I must say that innovative skills and lots of advancement, and it is nowadays approachable to many of us. In the past, it was that fetal medicine experts was not there, such a good machines was not there, trained person was not there. But now, as I am in the Muzaffarnagar Medical College head of department in the Uttar Pradesh, where lots of periphery. But even though the many fetal medicines are in the Delhi and even in all medical colleges, so we are doing well. So now it is a time then we have to we have to learn about the interventions, what interventions can be done, where it can be done, case with discussion as doctor has done. This was really very informative. And I think in next two talks, we will learn more. So without taking your more time, I don't want to come in you and between lectures. Thank you very much. And I have shared this links, your links to many of my students and my colleagues, and they are really very appreciating. It is a very good webinar. So I hope that this would be very beneficial for all of us. And again, congratulations to organizers, Aurangabad Obs and Gynae Society, as well as EMOS, and to organizing this and giving me opportunity to interact all of you. And we will meet non-virtually in some further conferences and webinars. So thank you very much. And myself is a candidate from the North Zone for the Vice President in coming year 2023. I was MTP committee chairperson in 2018 to 21. I have digital Foxy focus on MTP. I will share the Aurangabad office bearer. I will say EMOS, those who want to, they want it. And it is available on the Foxy website also. So you can have it. And please, again, give me your support for nomination as well as for voting, North Zone Vice President, Dr. Bharti Maheshwari. So thank you for inviting me, and thank you very much, and best wishes for the webinar. Yeah, Dr. Sunita.
Thank you, ma'am, for being with us and sharing your words of wisdom. We wish you all the very best for your presidential candidature.
Thank you. Thank you.
Now we'll move ahead to our second lecture, that is fetal interventions in complicated multifetal gestation. For that, I'd like to invite Dr. Vaishali Surase to kindly invite and introduce our speaker, Dr. Prashant Asegaonkar.
Very good evening. Yes. Am I audible?
Yes, yes.
Yes, yes. A very good evening to all of you. Under the able leadership of Dr. Sujit Konkar, we are having a very good webinar, a series of webinar on fetal medicine, which is a very good and upcoming topic. I thank Dr. Bharti Maheshwari ma'am and Dr. Sadhana Gupta ma'am for joining the webinar, and we wish all the luck to both of them from Aurangabad Obstetric and Gynec Society. Now coming to the topic, as we all know, that Dr. Prashant Tasegaonkar sir is one of the best fetal medicine in Aurangabad, and we are very proud to have him here. He is the director and consultant in fetal medicine at Garbhangpur Fetal Medicine Center, Aurangabad. He is the fellow and ex-consultant in fetal medicine from Simar, Kerala. He has a FMF certificate of competence, and he has an extensive work experience in invasive and very complicated invasive procedures also. And he has to his honor publications in the Fetal Medicine Journal. I thank him for being the part of the webinar and request him to go forward with his talk.
Thank you. Thank you so much, Vaishali ma'am, for the kind introduction. First of all, good evening all. Thank you, AMOX and AOGS, for giving me an opportunity to present my work over here in front of you all. Thank you, Dr. Pardeshi sir, Dr. Vare ma'am, Dr. Sujit sir, who is a senior come friend and who is always actively involved into the fetal medicine activities, be it in the AOGS or be it in the SFM. He is the one who is really propagating fetal medicine academics in our region. And thank you, Dr. Vaishali ma'am, for kind introduction. And I welcome Dr. Sadhana Gupta ma'am and Dr. Bharati Maheshwari ma'am. And many thanks to both of them for attending today's webinar. So without wasting any further time, I'll be proceeding to my talk today. So my talk is today on fetal interventions in complicated multifetal gestation. I have specifically mentioned it about complicated multifetal gestation because not every multifetal gestation you can just term it as a complicated one. I have seen where patients are conceived with only twin gestation and they are since day one afraid of that. They cannot carry the twin gestation where at the time of the scanning, both fetuses are being healthy. So such kind of pregnancies need not to be disturbed. That's why this is the name of the topic. So before coming to the fetal intervention, basic fetal invasive procedures, these are elaborated very beautifully by Dr. Saurabh in his previous talk, that is CVS amnio. Then these are invasive therapeutic procedures which are manipulation of the amniotic fluid volume, such as amnio infusion, amnio reduction, thoracocentesis and thoracoamniotic shuntings in cases of fetal pleural effusions, then vesicocentesis and vesicoamniotic shunting in cases of bladder outlet obstructions and megacystis, then intrauterine fetal blood transfusion. Again, a dear friend of mine, Dr. Chinmay sir, is there. He will be elaborating on IUTs in his next talk, and then intraamniotic drug instillation for fetal arrhythmias and various fetal conditions such as fetal goiter. What are the fetal interventions? Fetal intervention to
Sorry to interrupt, sir. Your slides are not visible.
Slides are not visible?
Yes, sir. Sir, can you try resharing it?
Should I? Now?
Not yet, sir. Yes, sir. Now it's visible, sir.
Now?
Yes, sir.
Am I audible? Slides are.
Yes, sir. Yes, sir.
Are slides visible now?
Yes, sir.
Sorry for the technical glitch.
Thank you, sir.
So, coming to the fetal interventions part, that mainly I'll be talking today in my talk about fetal reduction or selective fetal terminations. This can be done by intracardiac instillation of KCL in dichorionic, trichorionic, and quadrachorionic gestation, multiple gestation, And then cord occlusion. Cord occlusion using radio frequency ablation for complicated monochorionic twins, which I will be elaborating afterwards in my talk. Then there are drug or radiofrequency induced coagulation of the feeder vessels in cases of fetal tumors such as bronchopulmonary sequestration or placental tumors such as choreangiomas. Then fetoscopic laser photocoagulation for twin-to-twin transfusion syndrome, fetoscopic endoluminal tracheal occlusion, that is called as FETO, for congenital diaphragmatic hernia. Then now this new modality of fetal cardiac interventions are also tried for cardiac diseases, congenital cardiac anomalies. That is balloon aortic valvuloplasty in critical AS and pulmonary valvuloplasty in pulmonary atresia. These are on experimental basis. So before coming to the twin gestation, the genesis of the twins and chorionicity in multifetal gestation, we need to discuss it in detail. So when two ova are when dizygotic, the twins are mainly dizygotic or monozygotic twins. Dizygotic twins, how they are formed, that maturation and fertilization of ova during a single ovulatory cycle will give rise to the dizygotic twins, and monozygotic twins, when single fertilized zygote gets cleaved, then it will lead to the monochorionic twins in monozygotic ones. Then if a cleavage occurs between first 3 days of the then it will lead to dichorionic twin gestation. If it occurs between 3 to 7 days, then it will lead to monochorionic diamniotic twin gestations. And if it occurs more than 7 days, then it will lead to monochorionic monoamniotic twin gestation. So chorionicity is utmost important while doing any kind of fetal procedure or fetal interventions. Because modality of fetal reduction will depend upon the chorionicity, that how which method we are choosing to reduce the fetuses. When should chorionicity be assessed? It should be assessed before 14 weeks of gestation, and preferably at the time of dating scan itself, chorionicity should be mentioned. No report should be there like only twin gestation or twin pregnancy citing one gestational age for the one fetus and another gestational age for another fetus. This is a single gestation, though there are two fetuses, but gestational age cannot be different for the different fetuses. So that again needs to be considered. And chorionicity is seen beautifully apart from the converse to the notion that dating scan need not to mention chorionicity. I'll be coming to those slides also, where in the early gestational ages, chorionicity is assessed. How chorionicity is assessed? That ultrasonographic appearance of intertwin membrane, that is lambda sign or T sign, should be demonstrated, which I am showing it here. What is the twin peak sign or lambda sign? When the thin rim of placental tissue is seen extending between the two layers of amnion, will give rise to the lambda sign or the twin peak sign, which we call it as. If this sign is seen, then regardless of the thickness of the intertwin membrane, which we can firmly label it as a dichorionic twins. And in cases of monochorionic twins, this is the T sign, where monochorionic twins are separated only by the dividing membrane, and this membrane is angulated at right angle to the placenta. And am I audible?
Yes, sir, audible.
त्याने थांबवल्यावर आपलं क्लिअर करेल ह्याची काय गॅरंटी?
Hello.
Prashant sir, you're audible.
Lot of background noises are audible, ma'am.
I request everyone else to please mute yourself. Yes, sir.
Then monochorionic twins, where
हो
twins
मग
are
आता त्या संजयाच्या यांचं किती 50 लाख रुपये एका महिन्याचं झालं. मग आता ह्याला 15 दिवस ठेवणार, तर याला 4-5 लाख नाही लागणार?
Pardon me, Sujit sir.
15 दिवस आरामात राहील.
If you're there, can you please?
Hello.
Mute. Yes, sir, Prashant sir, please start.
Yeah. Sorry for the interruption. Then monochorionic twins, when these twins are separated by just a membrane created by the juxtaposed amnion of the both the fetuses, where you can see the T sign. So these two signs are of utmost important while assessing the chorionicity. If you are not seeing any intertwined membrane, make sure that you use transvaginal ultrasound with high frequency transducers to locate the membrane or to visualize the membrane between the two fetuses. Many times cases come to me for monochorionic monoamniotic twin gestation opinion. When we assess the chorionicity by transvaginal ultrasound, there is a membrane found in between the fetuses. So typing of multipetal gestation, these are the type of twins, triplet and quadruplets. I'll be elaborating and showing you the videos about this typing of twins rather than just enumerating them. So dichorionic diamniotic I have showed, monochorionic diamniotic twins I had showed in my previous slide. So these are the monochorionic monoamniotic twins where chorionicity was assessed at the time of dating scan by transvaginal ultrasound. No intertwined membrane was seen between the fetuses. And this is 12 to 13 week scan where you can nicely see both the fetuses in the single amniotic cavity and no intertwined membrane between them. So this is monochorionic monoamniotic twins. This is the trichorionic triamniotic triplet gestation, where you can see the lambda sign between the three fetuses. And this is the loop showing the trichorionic triamniotic triplet gestation, where you can see these two lambda signs. Then this is the dichorionic triamniotic triplet. Please bear with me for this chorionicity part, because I want to stress that there are n number of chorionicities and different permutation and combination of chorionicity and amnionicity. So before proceeding for any kind of fetal procedure or fetal intervention, one should be very well aware about the chorionicity. And it is not like that high-end machine or very much technical anatomical details to assess the chorionicity. It is a simplest part. If you are doing transvaginal ultrasound at the time of dating scan, you can assess this chorionicity. In this dichorionic triamniotic triplet, you can see lambda sign as well as sign in the gestation. And I am stressing upon yolk sac does not mean the number, like many times we are of the notion that single yolk sac and triplet this.
Sir, you are in mute.
Hello, sir.
Prashant sir, you are in mute.
Hello. Prashant sir, you are not audible.
Yes, he's trying to reconnect. There are network issues at this side. He's trying to reconnect. Today network is not good. On my side also it is not good. Poor today.
Maybe weather, cloudy weather.
Let's hope it will start. Yes, he joined. Let's hope we'll continue. Yes.
Is my screen visible now?
Yeah, it is visible now. Please continue.
Slides are not moving, sir.
Sir, click on one slide, sir. You will get to move
No.
other slides.
They are not moving. Huh. Are they moving now?
Yeah.
So should I resume, sir? Sujit, sir?
Yes, the video is, they are moving. Slide is not moved.
Now?
Yes. We can see the video.
Yeah, slides are moving, no?
Not, yes. No,
Yes, sir. Yes, sir. It's moving.
Yes.
Yeah. Some connectivity issue. This is the quadrachorionic quadramniotic quadruplet, where you can see this is not so uncommon even in like now so many IVF conceptions are taking place. As a referral center, we are seeing this kind of triplet and quadruplets. They are coming from all over the places, but this kind of chorionicities are also there. Then this is the trichorionic quadramniotic quadruplets, where you can see the three distinguishing placentas, and another one monochorionic diamniotic pair with a shared placenta. So this is the trichorionic quadramniotic quadruplet gestation. So coming to the fetal reduction or selective fetal termination part, why fetal reduction or selective fetal termination need to be done in cases of complicated multifetal gestation? It is to improve obstetrical and fetal outcomes. And in multifetal gestation of higher order, that is 3 or more in cases of non-anomalous fetuses, and twins which are discordant for anomalies or twins which are discordant for fetal aneuploidies, this fetal reduction can be performed in twins. When fetal reduction can be performed, it should be performed ideally after nuchal translucency scan, because again, chorionicity needs to be assessed at 12 to 13 week scan, if not done prior. Early fetal structural evaluation can be carried out in the same sitting and to carry out aneuploidy screening. How fetal reduction is to be performed? That is, there are two methods for dichorionic and triamniotic ones. Dichorionic and trichorionic gestation. It is intracardiac instillation of potassium chloride, and by cord occlusion by radiofrequency ablation in cases of monochorionic twins or dichorionic triplets. So rather than going into theoretical aspects, I'll be just putting cases one by one. There are in total 5 cases, and what all sort of cases were there and what kind of management has been done in these cases, I'll be elaborating. So case 1 is Primi gravida. She was aged 23 years. She conceived spontaneously and came for routine nuchal translucency scan in light of twin gestation. So upon assessing chorionicity, there was a lambda sign and it was a dichorionic diamniotic twin gestation. But when we in detail anatomical survey was performed and nuchal translucency was performed, we found that one of the fetus had a raised nuchal translucency with unossified nasal bone in one of the fetuses, where other fetus was having normal nuchal translucency and normal nasal bone. This is the normal fetus having 1.8 millimeter of nuchal translucency, and abnormal fetus is having 4.8 millimeter nuchal translucency. Then normal fetus was having ductus venosus forward flow. There was no tricuspid recurve, but abnormal fetus was having. This is the first case which I encountered all the 4 classical Down syndrome first trimester soft tissue markers in a single case, where NT was raised, nasal bone was non-ossified, ductus venosus was reversed, as well as there was a tricuspid regurgitation in the same fetus. Then what next? We performed chorionic villus sampling. Chorionic villus sampling is already told by details of which told by Dr. Saurabh. This is the chorionic villus sampling in anterior situated placenta. This is in the posterior situated placenta. Posterior situated placenta CVS, it might look simple, but it is technically very challenging to do CVS in posterior situated placentas. Then after doing the CVS, we did not wait for the results of the analysis, because all the 4 markers were present, and so something or the other must have been will be cropping up in the microarray analysis. That was the thing, and parents did not wish to take any chances even after the normalcy of the microarray report. So they straightforward in the same sitting decided to reduce the abnormal fetus. So this is the video depicting the intracardiac installation. You can see this is my needle, which is ultrasound guided and continuously ultrasound guided vision is there for the needle. Needle is pierced into the thoracic cavity and then into the fetal heart of the fetal heart. And afterwards, when the needle is reached within the fetal heart, we are putting, this is my needle tip in the right side video, we are putting into the 15% of the KCl solution. At this gestation, 1 to 1.5 cc of KCl is enough to stop the fetal heart. The confirmation of the stoppage of fetal heart is done by color Doppler or by power Doppler, and even in the loop mode, you can see that no cardiac activity is there. Confirmation of cardiac activity and documentation of the positive cardiac activity in another fetus is essential post completion of the procedure. Then the results arrived. The rapid aneuploidy detection revealed trisomy 21 in the affected fetus. So outcome of this pregnancy was she delivered at 39 weeks of gestation, healthy 2.75 kg female baby, alive and well. Coming to the case 2, it was a G2P1L0. She is 26 years, married since 4 years. Previous baby died due to multiple congenital anomalies. She conceived with, again, ovulation induction. Presented directly to me at 19 weeks of gestation. I don't know whereabouts of her first trimester scan, but her dating scan mentioned about the chorionicity. Then TIFA scan revealed anencephaly in one of the fetuses. This is the trichorionic triplet gestation with the fetus which was lying into the middle of the 2 membranes was having anencephaly. This is, you can see cranial vault is absent and brain tissue is free floating into the amniotic cavity. So what next? If left alone or expectant management in cases of anencephaly in triplet gestation, polyhydramnios will ensue. Subsequently, it will ensue about the preterm labor, then prematurity related morbidity, mortality, and prolonged NICU stay. These are the possible scenarios if we leave it alone. And what about active prenatal management or fetal reduction? If we are doing fetal reduction of the anencephaly fetus, prolongation of the remaining twin gestation to the near term, we are increasing the chances, and then favorable outcome with avoidance of neonatal morbidity for the healthy fetuses. So we performed fetal reduction for this anencephaly fetus. It is technically challenging to reach the particular sac and not to disturb other 2 membranes while putting in the needle. And care should be taken, utmost care should be taken while performing or attempting such kind of procedures in triplet gestation. So outcome in this pregnancy was continued till 36 weeks of gestation, and two healthy newborns, female and female, weighing 2.4 kg and 2.3 kg were delivered by LSS. This is the specimen of the reduced fetus post LSS. Then coming to the monochorionic twins, this is I told about dichorionic and trichorionic triplet. Coming to the monochorionic twins are often encompassed with complications. Most common complications are selective fetal growth restriction, twin-to-twin transfusion syndromes, monochorionic twins which are discordant for anomalies, then twin reverse arterial perfusion sequences, that is TRAP, and twin anemia polycythemia sequences. So these are the 5 main complications of the monochorionic twins. I will be discussing in depth about the first 3 complications because all the complications cannot be discussed over half an hour, and every complication requires elaborative detailing. So coming to the first case, selective fetal growth restriction, that is SFGR in monochorionic twins. This is the beautiful paper for diagnosis and detection of fetal growth restriction in monochorionic twins by Townsend and Asma Khalil, which helped me. What is selective fetal growth restriction? When selective fetal growth restriction in MCDA twins needs to be diagnosed, it should be either one of the twins is weighing less than 10 percentile for the gestational age, or growth discordance amongst the 2 fetuses is more than 20%. You are seeing it like one fetus is having growing appropriately for the gestation. She is 19 weeks, 1 day of gestation, and another fetus abdominal circumference is lagging. She is AC falls at 17 weeks, 5 days, and femur is also lagging by 2 weeks. The normal femur is somewhere around 19 weeks, and the smaller fetus is having 17 weeks, 2 days of gestation femur length, that is 24 millimeters. So coming to the typing, after diagnosis, we have to type the SFGR. The type 1, this FGR classification in monochorionic is different from the singleton FGR classifications. And these are like, depending upon the umbilical artery flow, we classify SFGR. Type 1 is forward flow in the umbilical artery of FGR fetus. Type 2 is either absent end diastolic flow or reversal of the end diastolic flow in umbilical artery of the FGR fetus. And type 3 is intermittent reversal of the end diastolic flow in the umbilical artery of the FGR fetus. So my case was fitting into the type 2 SFGR, where there was umbilical artery reversal and ductus venosus reversal in the affected growth restricted fetus. So what if FGR is left untreated? What are the fetal risks? If in monochorionic SFGR is left untreated, there are high chances that after a sudden exsanguination, the death of co-twin might occur. Even if co-twin survives, the surviving twin risks that twin is at risk of neurological damage. Why neurological damage? Because vascular anastomosis between the 2 fetuses will remain patent, and acute exsanguination from the survivor blood into the fetoplacental unit of the deceased co-twin might occur. So similarly, hypoxic ischemic damage due to cerebral hypoperfusion might occur due to hemodynamic imbalances. So these are the risks immediate, and this is like as good as pregnancy is lost if we are leaving it alone. So this is the new modality of treatment for treating complicated monochorionic twins, that is radiofrequency ablation for selective reduction in complex monochorionic pregnancies. This is the largest case series which I have come across. It is comprising of the 30 cases of RFA. It is done in the UK. So what is fetal reduction by cord occlusion by radiofrequency ablation? What is the principle and what is the definition? It is done for ablation of the blood flow in the umbilical cord to prevent acute intrafetal transfusion. So that sudden exsanguination which I talked about, which might cause neurological damage or hypoxic ischemic injury to the survivor fetus, is reduced. Sudden exsanguination is reduced because we are directly not stopping the heart. We are stopping the blood flow at the cord of the affected fetus. And then gradually over a period of time, like 20-25 minutes, after 20-25 minutes, the fetal heart is getting stopped. So the chances of take home of one baby increases multifold with this modality. And these are the principles of RFA. RFA uses it generates changes in the alternating current at very high frequencies, and it in between the times of the radio frequency probe. And electric current which is generated, it will alternate in various directions between the tines of the needle. After that, tissue ions will become agitated and they attempt to align with the electrical field. After that, frictional heat is produced and it will result in very high tissue temperatures, which will cause necrosis and tissue coagulation. So what are the prerequisites of RFA? First of all, fetal medicine specialist who is well aware with the invasive fetal procedures. We cannot just go and directly do radiofrequency ablations. We have to start from the basic like chorionic villus sampling, amniocentesis. There is a steep learning curve of this fetal invasive procedures. And once you keep on performing this invasive diagnostic procedure, the slowly confidence gets built up and then you can perform the additional fetal interventions which are available. So again, chorionicity needs to be established before proceeding to the RFA. Good ultrasound diagnosis and USG documentation of complication in monochronic twins should be done. It is just not like in monochronic twins and you have to get one of the fetus reduced. Only when the monochronic twins are posed with the complication, then only this modality should be tried. Thorough counseling regarding pros and cons of the procedure, you have to put forth the benefits of the procedure as well as complications of the procedure, alternatives to the procedure, and option of expectant management should also be discussed. It is not that you are doing a procedure and you are pushing for the procedure for this kind of twins. You always have to explain that expectant management can also be tried in this kind of cases, and what if expectant management is to be carried out. So the counseling is non-directive in such kind of cases. Then RFA electrode and generator availability is a major issue. Team comprising of trained staff, anesthesiologist is required because of deep sedation is required, and then RFA generator operator is required. And most importantly, as Sadhana ma'am told initially, that all relevant PCP entity forms should be duly filled, signed by doctor, patient, and relatives. This is before performing any invasive fetal procedure. Then written informed consent also. Before doing any procedure, you have to do it in a local language which patient and relatives should understand. And then procedure related risks and complications should be well explained in a local language. Then pre-medication and deep sedation to the mother, and under all aseptic precautions, the procedure should be performed with good antibiotic coverage prior to the procedure. You can give Proluton injection also, one shot before the procedure, and one sustained tablet per vaginum before one capsule sustained 200 mg before proceeding for the procedure. And good fetal position is required before doing RFAs. So this is the team effort, not a single person's job to perform radiofrequency ablations. This is the image which for RFA electrode placement. I'll quickly run through the videos. I know I am late for my talk. Fetal reduction by cord occlusion. In this video, you are seeing my RFA electrode is getting placed at the insertion of the cord, which is technically challenging. Fetal position has to be proper. Fetal spine needs to be posteriorly facing. If fetal spine is anteriorly placed, then you have to wait for the fetal position to change. And then after the RFA electrode reached within the cord of the affected fetus, you can start coagulating and increasing the temperatures. You can ask your RFA generator operator to slowly increase the temperature. Temperatures can be rose up to, like, you can start from 80-85 degrees and they can be rose till 95 to 100 degrees Celsius, so that tissue can coagulate, and then umbilical blood flow at the cord insertion should be stopped. So this is a short video while doing the radiofrequency ablation. This is RFA electrode placed at cord insertion of the affected fetus, and you can see the coagulation taking place. As soon as the temperature is increasing, this is RFA in progress. This is the RFA electrode, and it is done under continuous ultrasound guidance. After placement, you have to, for completion of the RFA, you have to use the color Doppler to see for the stoppage of the blood flow at cord insertion. And then using power Doppler, you can confirm the absent cardiac activity like 30 minutes to 40 minutes after the procedure. Fetal heart won't stop immediately as in the KCL method in RFA. An outcome, this is the remaining pregnancy was continued and delivered at 35 weeks of gestation. This is the 2.2 kg healthy female child, alive and well. Then coming to the TTTS complication, this is a unique complication which is in the monochorionic twins. Actually, TTTS is a misnomer because intravitreal transfusion across the anastomosis occur in all monochorionic twins and not only in a TTTS cases, but only in 10% of monochorionic twins, a chronic imbalance in the flow develops and TTTS will develop in these cases. So diagnosis of TTTS, single vertical pocket should be more than 8 centimeter in the polyhydramniotic sac, and the single vertical pocket should be less than 2 centimeter in the oligoamniotic sac. This is the diagnostic criteria of the twin oligopoly sequence or twin-to-twin transfusion syndrome. So the bladder, the donor bladder is not visible where the recipient bladder is enlarged. This is the loop showing the composition of TTTS, where you can see the polyhydramnios in this particular loop, and oligoamnios. Almost you can feel like that there is no membrane between the two fetuses in cases of TTTS. But if you look carefully, then you might find these membranes which are wrapping around the donor twins. These are the membranes, and these membranes will be more prominent at the limbs. So you have to actively seek for it. Then this is the quintero staging of the twin-to-twin transfusion. There are 5 stages of quintero staging, and not necessarily it will progress stage-wise TTTS. So when MEP or single vertical pocket is less than 2 centimeter, I already told non-visualization of fetal bladder. I have shown you. Then Doppler is required from stage 3 onwards to stage the monochorionic complicated TTTS. Absent or reverse umbilical artery diastolic flow or reversed diastolic flow or ductus venosus A wave flow or pulsatile umbilical vein flow. These all come under stage 3. Stage 4 is fetal hydrops in one or both of the twins. Then stage 5 is fetal demise of one or both the twins. And this is the Doppler, where donor twin is having forward flow in the umbilical artery, whereas the recipient twin is having absent in diastolic. So what again, if expectant management is to be continued, the fetal risks are donor twin risk will have hypovolemia, hypotension, and anemia. Recipient risk, again, if a donor is having hypovolemia, recipient is bound to have hypervolemia through anastomosis, and cardiac failure subsequently may ensue. And again, cerebral imperfusion is the culprit. Surviving twin risk, neurological damage to the surviving twin is the most potential risk. Even if a twin survives, it will have an abnormal neurodevelopmental outcome. And maternal risk like placental abruptions, chorioamnitis, and preterm labor due to polyhydramnios. So what she presented at 20 weeks of gestation, and she was having much discomfort due to polyhydramnios. Immediately, procedure was not possible. So to elevate the maternal symptoms, we performed the amnio reduction from the polyhydramniotic sac. Around 1200 to 1300 cc of amniotic fluid was drained. The amnio drainage was performed, and maternal symptoms of breathlessness were reduced before actually doing the procedure. Then while performing the procedure, we have to aim for the donor twin, which is the growth restricted fetus where bladder was not visible. But as I have demonstrated, the membrane was hardly seen between the fetuses. So you have to perform amnio infusion first. This is my needle where I had gone inside the oligoamniotic sac, and then we have performed amnio infusion before proceeding for the actual RFA procedure. You can see the jet of the fluid here through the needle. So after performing the amnio infusion, you can see the membrane is visible, and we can go for the donor twin radiofrequency ablation. So after that, this was a very complicated and challenging procedure. After doing amnio infusion, you can see the recipient twin, which was a bigger one, which was obstructing the view of the donor twin. And though the fetus was in a position, the cord was accessible, but in the needle, like part of the needle, this fetal lower limb was there, which was a very much challenging one. Then we have to wait for that limb to get aside, and then to perform the procedure. This is the actual procedure when we had gone after the limb was again, we had introduced it into the cord insertion and then perform the radiofrequency ablation of this affected fetus. Again, the steps are same to confirm the absence of cardiac activity, and the outcome is she went into the preterm labor because of her polyhedral news, but since 20 weeks to 30 weeks, we have managed to give her 30 weeks. And it was a 1.5 kg male baby. It was in NICU for 21 days, but now it is alive and well. So if we had done nothing, we had just told that this pregnancy will end up in termination and all those things, this baby wouldn't have seen the light of the day. So that is beauty of the procedure. The third case of monochronic. This is my last case. I'll just take 5 minutes more. Monochronic diamniotic twins, which was discordant for anomalies. At the time of NT scan, she was referred to me in light of twin gestation. It was a monochronic diamniotic twin gestation conceived after IVF. One of the fetus was having 18 millimeter nuchal translucency, another was having 2 millimeter. Then it was a monochronic twin gestation. This is the T sign, which we confirmed. The fetus was hydropic. This is the cystic hygroma you are seeing. And this was the normal fetus. So there was a discordancy amongst the two fetuses for anomaly. One was a hydropic fetus, you can see here. And this was the normal fetus. So before performing radiofrequency ablation in this case, we had to go first, and because radiofrequency ablation you cannot to reduce the energy and time for the procedure, you have to first of all drain the ascitic fluid from the abdomen, so that size would be reduced, and the energy required to coagulate at the level of the umbilical cord is less, and time taken for the procedure is less. So this is my needle. I had first gone into the fetal abdomen, and then I had tapped it. This is the tapping video. You can see the amount of ascites in to left of my screen, and to right of my screen you can see after draining the ascitic fluid, this ascitic fluid is reduced. And then actual procedure. But before performing the actual procedure, we had done amniocentesis from both of the sacs, because one fetus was hydropic and another fetus was normal. That doesn't mean that normal fetus would have like chances that normal fetus will have normal karyotype only. Sometimes it may happen that there are heterokaryotypic monochronic twin gestations are also there. So this is the heterokaryotypic monochronic twin pregnancy. It is very rare. I have found only 7 cases before this case in the literature, which are documented as of heterokaryotypic monochorionic gestation, where one fetus was having 45 XO karyotype and another fetus was having normal 46 chromosome complement. So this is also important. Whenever there is an anomaly, many people advocate that it is a monochorionic twin, you just go into the one of the sac and sample both the fetuses. It is not correct. Whenever there is discordance, whatever it is, monochorionic, dichorionic twin gestation, because dichorionic twins are also like not 100% dichorionic twins are dizygotic ones. There are 10% of monozygotic twins which might go which might be dichorionic ones. So anything which you are finding it on ultrasound in twin gestation, you have to sample both the sacs. So that is my message. And even though it is monochorionic twin gestation, you can see different karyotypes in this case. And again, outcome was wonderful. She delivered full term. Again, healthy female child. So what are the take-home messages? I know it's been a lengthy presentation, but take-home messages for my RFA presentation would be multifetal gestations will need to be evaluated meticulously by prenatal ultrasound, and the operator who is going to do fetal procedure, like Saurabh told in his previous talk, that if somebody has told that, sir, do the procedure for unossified nasal bone, you cannot just make the patient lie down and do the sampling and later go away. You have to first confirm whether those findings are correct or not. Whatever it is, you have to perform prenatal ultrasound by yourself. It doesn't matter who has done previous ultrasound and what are all the findings. You cannot just get deviated by the previous ultrasound reports. At my center, we have made it a policy that I don't see, like I just take a history, but I don't see whatever is written in the prior report. So that sometimes even you get biased about your diagnosis. So you have to do your prenatal ultrasound yourself. Then chorionicity assessment importance I have stressed. I won't be elaborating about it. Early fetal structural evaluation needs to be done at the time of NT scan, and it is a must in cases of multifetal gestation. In cases of complicated monochorionic twins or higher order gestation, options of fetal intervention in the form of RFA should be discussed with the patient. Rather than directly, I have seen the cases monochorionic, there is a trap fetus, there is TTTS fetus. So they have gone somewhere and directly terminated the pregnancy. You don't know how much effort has been gone into creating that pregnancy, how much IVF cycles she might have taken, or whatever it is. You don't know her marital history and all. For this pregnancy, very precious to her, you can give her an option. Whether they are opting for that option or not, it's their perspective. But without giving them option that no, this nahi hota hai, like it won't happen and it is not successful, complication rates are high. If we go on saying like that, then that fetus, which is healthier one, will not see light of the day. And one should always be aiming for saving a precious life rather than thinking of affordability and cost effectiveness. I had attended one of my senior Dr. Chinmay Ratha ma'am's talk, and she told that patients' affordability should not be treating doctors' guilt. This is not my sentence, but Chinmay Ratha madam's sentence. And you have to offer all the management options. You never know. Like the patient who is spending 1.5 lakh for the IVF treatment, he or she might go for the treatment in order to save her fetus, just to create a pregnancy or just to do a successful IVF, that she is conceived and UPT is positive, that won't suffice. You have to take it to the term. So all the complicated pregnancies can be managed, and these procedures are very much available in our own city, and no more roaming around in metros for these procedures. Thank you so much. And happy patients is to conclude with is not a myth. Happy patients are there everywhere, and these are the all little lives, not necessarily for RFS, but this is what keeps us as a fetal medicine specialist going. The parents which were denied, or somebody has offered termination, or they were in dilemma about what to do in this pregnancy, then we have offered them a correct guidance, correct management options, and then when these babies are all grown up, they have come to meet us, and this is the joyous thing which we encounter in our medical practice. So thank you so much for patient hearing, and for the technical glitches, I am again sorry from my end. Thank you.
Great work, sir, and very nice presentation. We really appreciate the efforts you have put into the fetal intervention procedures. I particularly like the use of cine loops that you have done. You kept everyone engaged throughout your presentation. Thank you very much. I would now request Vari ma'am to introduce Chinmay Umarji, sir.
Is he there?
Hi.
Can you hear me, Vari ma'am?
There, but she's muted and.
Do the introduction, Sunita.
Sorry. Dr. Chinmay Umarji, he is an MBBS, DGO, MRCOG, London, UK, MRCP, Ireland. He has done research fellowship in maternal and fetal medicine. He is in charge of fetal medicine unit at BJ Medical College and Sassoon General Hospital. He is member of Antenatal Screening Committee, Government of Maharashtra. Coordinator of Fox Imaging Science Committee. He is Secretary of Society of Fetal Medicine, Greater Pune chapter, and he is reviewer of Journal of Fetal Medicine. We welcome you, Chinmay Umarji, sir, and we'll request you to talk, deliver the talk. Over to you, Chinmay, sir.
Thank you, Dr. Sunita. I would sincerely like to thank Dr. Sujit Konkar, Dr. Prashant Asegaonkar, Aurangabad Obs Gynae Society and AMOGS for this opportunity. I hope my screen is visible. Greetings to all of you from Pune, and I would love to invite you all for our upcoming exciting conferences. HRP is coming in March, and then there is an exciting conference in May again. Without further ado, I'll not keep you away from your patients and dinner. Let us move on to today's topic, which is fetal anemia. And Saurabh and Prashant have made my job so easy. He has shown high drops, they have talked about aneuploidies, they have talked about invasives. And I'm sure if facility was available locally for MCD8 twins with TTTS, fetoscopic laser ablation would have been the first choice of Prashant's. Because the facility is still building up at the moment, probably locally RFA is available or interstitial lasers are available, which Prashant is doing so effectively. So I was very, very pleased to see that. Now, moving on to fetal anemia and its causes, apart from aneuploidies, which Saurabh mentioned, the TTTS, which Prashant has elaborated on, these are the other causes. When we talk about anemia, first thing comes to our mind is rhesus isoimmunization, which is the commonest. We should not forget about parvovirus B19. So always ask her about the history, especially of a slap chick. Non-rhesus isoimmunizations also form a significant chunk, which we tend to forget. And then there are rarer causes of fetal arteriovenous fistulas, placental tumors, alpha thalassemia, and other metabolic disorders. Before I go to the big elephant in the room, which is isoimmunization, let me talk about the others. So for parvovirus B19, you just probably need to monitor the babies, sometimes give a top-up transfusion if there is, I hope I am audible.
Yes.
Yeah. Give a top-up transfusion if needed. AV fistulas of the fetus, they're difficult to manage. For placental tumors, the same thing which Prashant has so beautifully shown on the fetuses, you can do it on the placenta. So if there are vascular connections in the placental body, you can burn them with the help of RFA, and it is very easily manageable. Aneuploidies, Saurabh has very nicely elaborated about them, so I'm not going to go back to them. However, before testing them for aneuploidy, as Prashant had suggested, people come from all the backgrounds. They may have all the ethoses and you don't know how they have reached that pregnancy. So instead of being the undertaker who wants to offer termination, give them the choices. tell them what may realistically happen, say if a Down syndrome baby were to be born. If they want, connect them to your existing patients with Down syndrome. And you'll be surprised to know that some of your patients may still want to go ahead with the pregnancy. If you insist on a termination, they may abscond from the medical services. So always give them a cafeteria approach when it comes to testing or screening for Down syndrome. For conditions like alpha thalassemia, which were considered untreatable until recently, now there have been RCTs in place and the results are yet to come out, but the initial case reports are very, very promising with fetal stem cell therapy, especially from East Asia. And for metabolic disorders, of course, we may not have much of a solution. However, tasting these babies can tell you more about the etiology, give you an opportunity to test the parents, and if they test as carriers, you may consider about the future pregnancies as well. Now, let us come to the big elephant in the room, which is fetal isoimmunization. I think all of us know the pathology, so there must be a sensitizing event, and there have been reports of sensitizing events of bleeding in early pregnancy. So even implantation bleeding sometimes, even bleeding in mid-trimesters have known to cause maternal-fetal hemorrhage, rather feto-maternal hemorrhage, which leads to sensitization in the fetuses. So prevention is the best cure. And this is a general outline of what a general obstetrician can do for all their patients. I say over here, ICT, indirect Coombs test, at booking for all, and to repeat it again at 28 weeks for all, not only to your rhesus negative patients. Also, especially in the periphery, please insist on getting a printed blood group report. Sometimes patient may tell you verbally something, and even with educated patients, sometimes rarely with doctors, I've seen that they're surprised to see that their blood group is different than what they were mentioning. Do take care of sensitizing events. Keep in mind that all the episodes of hemorrhage or even spotting during pregnancy are sensitizing events. Your doctors have so beautifully shown us today the invasive testing, and invasive testing or therapy is also a sensitizing event. You need to adequately cover these mothers with appropriate dose of anti-D at all these events. When it comes to RAADP, that is routine antenatal anti-D prophylaxis, you should offer it to all at either 28 weeks or 28 and 32 weeks as per your local protocols. And it is quite essential that postnatally you do the baby's blood group, but please try and see if a Kleihar Bedke can be offered. The standard dose of 300 micrograms, which is 1500 units, covers only 96% of RH feto-maternal hemorrhages. So RH sensitizing event in as many as 4% rhesus negative mothers is not covered by the routine dose of 300 micrograms. Especially during cesareans, you may have more feto-maternal hemorrhage, and many times these mothers need more anti-D doses. And that is probably one of the common reasons these days why we are coming across RH isoimmunization. You ask the mother and she tells you that she did receive anti-D, but maybe it wasn't antenatal or it wasn't the appropriate dose. So please work on that. Now let us come to the topic of interest. So when you see a fetus with anemia, you first need to understand if it is isoimmunization or non-immune hair drops like Prashanta's baby had. You want to rule out aneuploidies before you start treating these babies. You don't want to give 3 transfusions and then tell the parents that, listen, although baby's anemia is cured, you have a Down syndrome baby. So please keep that in mind. Monitor the fetus regularly. You may, of course, go for timely delivery. Talk to your pediatricians and neonatologists and time for delivery at appropriate timings. Till that time, you may consider intrauterine transfusions. And of course, post-delivery care of the newborn is absolutely crucial. These babies may need treatment for around 1.5 to 3 months postnatally, for which you need to prepare your parents antenatally. So let us cite one case, G7, P4, only one living issue, B negative, referred with head drops. So if you look over here, hi Radhika, apologies. So you can see there is ascites and there is pericardial effusion. She had all normal deliveries. The elder child was 16 years old, and there were so many pregnancy losses between that pregnancy and this pregnancy. So she had lost 5 pregnancies, of whom 3 were beyond the gestation of 37 weeks. I'm going to skip all of this. So she came, I think, 150 kilometers away from Pune, and there was no history of previous losses, which was available. So she did not have a single piece of paper about those pregnancies, and there were no investigations done on those demises. So if you don't have investigations, you have to think of NIH as well as immune hydrops, non-immune as well as immune hydrops. And what you should do is very beautifully elaborated over here by SUGC, Society of Obs in Gynae Canada. And they suggest that these fetuses are best managed in a tertiary care or for chromosome analysis. And I'm going to skip over this for the short of time. So I saw her and I had to perform an anomaly scan at 27 weeks. Luckily, whatever I could see, the fetus was doing very well otherwise. I had sent her ICT, which, no surprise, came as positive. When ICT comes positive, please remember to do a reflex 11-cell panel testing. 11-cell panel will tell you what all major and minor antibodies the mother is harboring. In this case, she had anti-RH as well as anti-KEL antibodies. Father was rhesus positive, so it was safe enough to say that the baby could be positive. And we went ahead, we started monitoring the mother. And of course, no surprise, her peak systolic velocity in the middle cerebral artery was very high. Again, remember that gone are the days of Lilly charts. And what we have started doing is now looking at the middle cerebral artery peak systolic velocity, which has very good sensitivity of around 99%. I also did her anti-D titer, which was pretty high at 1 in 1024. So I wanted to treat her for her fetal anemia. So here what we established that anatomically the fetus looks okay. I had done ICT, which confirmed isoimmunization. I did 11-cell panel, which confirmed RH isoimmunization with KEL antibodies as well. I have looked at her previous data, which I had none. So I have offered them microarray, although the patient was just a poor farmer from the periphery, as cited by Chinmay Ratha's quotation there. One should not be the finance minister of your patients. So please offer everything you can scientifically. Let them choose what they want to and just document. You need not insist on those tests. And of course, when you're considering treatment for fetal anemia now you know that, listen, there is, and maybe, I mean, there is isoimmunization, probably rhesus. So let us give intrauterine transfusion to the baby. How will you give the transfusion? That is through across the placenta under ultrasound guidance. And you are going to use O negative blood, which should be hemoconcentrated. Remember, your fetus is already volume overloaded. So you don't want to give them whole blood. It should be fresh, because if you give older blood, it will have, apologies, am I audible?
Yes, sir, audible.
Yeah, thank you. So if you give older blood, it will be, it will have lesser viable RBCs. So your next transfusion will be kind of coming up very early. And of course, it should be leukocyte depleted. It should be irradiated. And here you want to cross match it with the mother, because you don't know what is the fetus's blood group. You have already given O negative. Ordered O negative, but always cross match it with mother, so that mother does not get any reactions. So what we usually do is, when we get across these patients, we call our blood bank. The blood bank in turn calls their list of O negative donors who come in afresh. And within 24 hours, we rapidly build up our blood. We do all of this, and then we transfuse. So it is very essential that you have good rapport and good donor list with your blood bank. Now moving on. This is how you actually do the transfusion. So that is my needle, which is going across. Here I have the liberty of posterior placenta. So I have paralyzed the fetus. You can see that small crescent, my cursor hopefully is visible. This small crescent over here, that is the ascites. My needle here is going into the fetus, into the umbilical vein where it goes into the portal at that juncture. I've aspirated the blood now. You can see my needle is going out. I've aspirated the blood and tested it for the fetal blood group. I also do a fetal hemoglobin at this stage with a rapid device, which is right next to my bed. So it's a bedside test on a device called HemoQ, a very versatile machine, very cheap, and quite useful even for PPH. So you can get immediate blood count. So the fetal hemoglobin at that stage was 2. This is, I think, the other placenta. Again, this is anterior placenta. So here, when you are trying to give intrauterine transfusion, you can go transplacentally at the base of the cord. So here you need not go into the fetus. That gives you the liberty of being stable. So that's my needle there. Moving on. So this was their initial scan, 69 MCA PSV. Then I gave the blood, so it came down. I did not overload it, because sometimes overload can put these babies into cardiac failure. I again monitored the baby the very next week. There was anemia, but not to that level. There wasn't much of hydrops at this stage. So I again transfused. This time I took the liberty of overloading. And then after that transfusion, there was time for delivery. After that, she did not develop anemia again. So we could safely deliver the fetus at around 34 weeks, and the newborn weighed 2.4 kilos. At delivery, the hemoglobin was 9.5 gram. It was managed for 3 months for anemia, because of the repeated blood transfusions, these babies go into bone marrow hypoplasia. Their bone marrow forgets how to manufacture blood, and you need to support them even postnatally for the same purpose. We did the blood group at birth, which was B negative, and I wasn't surprised at all, because I knew that the mother was negative, B negative, and I also knew that I had given O negative blood to the baby. So B blood group of the baby and being negative would not be very, very surprising in these cases, because there is bone marrow hypoplasia. Baby is not manufacturing much of blood, and you're topping it up with O negative blood. However, after 6 months, when I repeated the blood group, it was still B negative. And then I concluded that probably this was anti-KEL antibody, which is very rare, and the presentation of this sort is also very rare. but that may happen. So the take-home message would be that even if she were rhesus positive, she would still end up in similar consequence because of this antibody. In other words, your other rhesus positive patients should also get indirect Coombs test at booking and again at 28 weeks. And realistically speaking, this is not Dr. Umarji saying, all the guidelines across the globe tell you to look for mother's blood group and antibodies, which we forget because we have never thought about antibodies in our blood group or hematology lectures, right? So every guideline now, when you go back, look at RCOG, ACOG, every guideline, they'll tell you blood group and antibody screening in the booking panel. So please, 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 from today onwards, please offer indirect Coombs test to all your patients at booking and again at 28 weeks, because these googlies could be avoided then. Now, the obvious question my junior consultant asked me was, sir, kitna anti-D dene ka? Please remember, this is a manufacturer of anti-D. She has so much of anti-D in her body that she can supply to the others. She does not need anti-D injection after this delivery just because she is rhesus negative. And it's not about getting photographs in the newspapers, but as Prashant rightly said, it's about the smiles on the parents' face, but most importantly, about saving lives. So take to work messages are, first and foremost, rhesus isoimmunization and other isoimmunizations have 95% survival. Please remember, hide drops, refer them appropriately to a tertiary care unit, confirm isoimmunization, rule out aneuploiditis before treatment, always, always, always a must. Monitor the fetus, timely delivery versus IUD is your choice, and you need very strong post-delivery care for the newborn. Thank you so much.
Thank you. Thank you, Chinmay sir. That was an excellent talk. You could only probably pull it off, and some new things to learn, as always. So my only question is, nowadays self-repeatal DNA is very popular.
Yes.
So would it help in this kind of other than anti-D, like what you had told in your talk about anti-kill isoimmunization? So basically self-repeatal DNA is going to tell you only about the positivity and negativity of the blood group.
That's correct.
That's it. Like in your case, blood group, despite being negative, these all things have happened.
Yeah.
So whether to offer, how to reassure, many a times, like I am not very much advocate of self-repeatal DNA for blood grouping purposes.
Right.
But now slowly these things are catching up, and people are asking about it when it is a subsequent, like second pregnancy in Rh negative mother.
Yeah.
So your take on it. And as again, like thank you for the wonderful talk, and it was a pleasure hearing you.
Thank
with
you.
All these real case scenarios.
Thanks a lot. And thanks for the excellent question, Prashant, because self-repeatal DNA has been launched by one company so far, to the best of my knowledge, in India.
Yes.
However, other companies are going to rapidly catch up, and it will become...
It's available at Gangaram.
Yeah. No, now one of the bigger ones is also. So with Gangaram, what happens is you cannot do it from home. You have to send them physically to Delhi and then do it. Now, one of the bigger ones is planning it. Rather, it was supposed to be launched last month, but for some
launched.
We
won't be taking any names.
Yeah,
it has been launched.
So, all right. So that's what they had told me. So, but others are also catching up, and it's an excellent test if you want to avoid anti-D injections in a patient. In other words, if you are see, what happens is, if you are doing rigorous antibody screening, you know that your patient does not have other antibodies if your ICT is negative.
But that 11 cell panel is not everywhere.
No, ICT. You need to do just the ICT, number one. Number two, 11 cell panel is a very simple test for which patient need not travel physically. The aggregators can transport the samples. There is no time limit on it. So they can very comfortably do it if they want to. And we can refer to the, so initially when I came back to India, it wasn't available in Pune. Till our lab started doing it, we used to send our samples to Mumbai. So that can be very easily managed. And it's not a very expensive test. I think 1,000 rupees to the patient. So not very expensive. But you don't need to do 11 cell panel for everyone. What you need to do is ICT, which is locally available. If your ICT is positive, you cannot excuse yourself out of 11 cell panel, right? Because there could be surprises. Now, ICT could be positive even for rhesus positive patients, and that is the take home message. Now, for minor antibodies, if your ICT is negative, you don't want a cell-free fetal DNA. For major antibodies, if your ICT is say positive, then you will so my 4-year-old also is quite interested in rhesus isomerization. So for your ICT positive patients, if you order D-antigen testing on cell-free fetal DNA, it has very good sensitivity in the Western world. I don't know about the current panel being offered by the company here, but it is at the upwards of 99.9%. So in the past, when I have had expats who come to me and they say, listen, doc, if I'm rhesus negative, my partner is positive, if I don't want to take anti-D, what can I do? So we do their ICT, and if ICT is negative, we do their cell-free fetal DNA. If cell-free fetal DNA shows that fetus is rhesus positive, then only she needs an antenatal anti-D prophylaxis. And of course, postpartum. If the and why do you want to avoid anti-D injections is that small risk of prion diseases. So there were some labs in Ireland which had some contamination of their anti-D immunoglobulin, anti-D this thing injections, and that had potentially theoretical risk of prion disease being transmitted through the injection. And that is the reason why in the Western world, they would want to avoid anti-D injections. The incidence of prion disease is extremely rare. In India, I don't think we are at that level right now for our general population to offer D-antigen testing on cell-free fetal DNA.
Thank you.
Thank you so much. And thanks, Dr. Konkar, Amox, and Aurangabad Obs Gynae Society.
On behalf of Aurangabad OBGYN Society and Fetal Medicine Committee AMOX, hello. On behalf of Fetal Medicine Committee AMOX and Aurangabad OBGYN Society, we would like to thank our chief guest, Dr. Sadhna Gupta ma'am, guest of honor, Dr. Bharti Maheshwari ma'am, President of Aurangabad OBGYN Society, Dr. Anjali Vare madam, Secretary Dr. Vaishali Surase madam, our talented speakers, Dr. Saurabh Chaudhary sir, Dr. Prashant Asegaonkar sir, and Dr. Chinmay Umarji sir. Thank you all for your contribution. We are also thankful to Dr. Sujit Konkar sir, Chairperson of Fetal Medicine Committee AMOX. Last but not the least, Shield Healthcare, who gave us academic support. So thank you.
Let's end up.